Pour une fois, je vais me permettre de tutoyer mon vieux copain.
I will actually speak informally with my friend Richard Villet because it's been approximately 50 years since we met each other. And he is the surgeon and gynecologist, and he's working with women, and I'm working with men. So we are basically repairing the couples, we can say so. And yes, I also was, if you would like to put it this way, I was also at the origins of the term perineology. So yeah, within this framework, and at the same time, we're very often meeting at the Academy of Medicine. And personally, I am convinced that we have created this training, which is the training of surgeon and operator. And today, when we're looking at the orthopedics, we can see that we have the wrist, then the elbow, then the shoulder, then we have the knee or the hip, and everyone is very much specialized. So everyone is hyper-specializing. And right now, we are coming to this engineer job, which is the job that has worked with robots, and knowing that the anatomy, as we have learned it, it was the queen of the sciences for all of the surgeons. So all those robots that I have seen in neurology, that through the perineum will put a small needle through a small and insert a small support with iode in a very small area for the cancer of the prostate, and it will actually be doing it alone. So the program, the software is prepared and the machine is acting on its own, and the surgeon, the neurologist, will be working on the perineum, like you will be working with female organs, and I will be working with male organs, and well, it's actually very interesting. So it's interesting for me to know what you think about it, but just to finish it, the surgeons that we know, well, we have more and more female surgeons, and this is absolutely great. And I actually wanted to remind you that the insurance companies said that the ideal woman for the surgeon is a 45-year-old woman. Well, look, I am very, very sensitive, and I like very much this invitation that you have issued to talk about the surgeon engineer. And there are three important points that we can talk about together. So first of all is the type of the intervention, because we have some standardized codified interventions, I think we can call them so, and then we also have the unstandardized things, so we can basically eliminate all the emergency here, and this is also one of the biggest problems about the trainings of the surgeons that don't know what to do here. So the army is basically taking care of all of those people who have been, who have had these wounds. So the intelligence of the robot, I think, is not enough when the decisions are well too important. When you have been talking about the surgery and you talked about this incisions or interventions in the prostate and so on, we have some standardized processes and interventions. So there is a conception, there is a discussion, there is a resolution, and of course we will be using some algorithms. So this is what we are doing for some other surgical interventions that are done by robots. So we have a sum of information that allows us to delegate this gesture to the machine. But there are also some other areas for these types of interventions that are completely codified, the interventions that cannot be codified also, and this is where the problem of the surgeon is. The problem is to know whether through the repeated algorithms and probably through the generative intelligence that remains with robots, we will be able to solve this difficulty, because I believe that the difference between the craftsman approach, I would can say the simple craftsman approach, because there is a conception, a resolution and an execution, and this is absolutely feasible, and then the other one, which is not like craftsman approach but acting approach, and this was the role of the surgeon that we have learned back in our time, is to translate our thought into action. So we actually need to judge instantaneously at the moment of the surgery. So this is the first comment that I would like to emit, which is to say that probably the robot and the engineer will be here, and the new surgeon will have to know a lot of things. Well, I think that me and Guy, we just during the surgery, if we didn't know what was the computer and so on, it was very complicated for us. So, well, right now we actually need for the surgeon to be a little bit an engineer as well. But I believe that for the the rest of the surgical techniques, I'm not sure whether the robot will be able to learn them. Well, of course, all the typical actions and interventions, and I don't want to offend anyone here. Well, for the prosthesis, it's not very easy either, but this is standardized process. Well, of course, we understand that there are many disciplines, different disciplines like prostate and ophthalmological surgeries and things like that, where the robots can be very useful and help a lot in the intervention. So this is the first reflection that I wanted to launch. And now the second reflection that I would like to launch goes back to what Karen Maromi has already said, is that the patients are very much ambivalent. So they say, when you receive them, they say, do you have a robot? Yes, of course, we have the robot. So yeah, this is the expression that I actually love very much, just going back to my colleague VILLET, who was saying, who was being asked, do you do the surgery with a laser? He said, yes, the laser that is useless. So it's basically like asking to have this extreme technology, but being ambivalent here, because I'm working a lot on cancers as well. And well, people would be like, we didn't talk, no one talked to me, no one took care of me, or things like that. So this will be the reproaches. So this is why it's very important to look at this duality that exists between the technology, surgical technology, and the fact that the surgeon has to be an engineer, and how can we satisfy in the best way possible the needs of the patient. So what is the prognosis and what is the forecast for this person, and so on and so forth. Yes, now to reply to you, of course we will have the surgeons that will be here working with a lot of different diseases and so on, things that cannot be foreseen by the AI, and this is something that will remain manual for the human intervention. I completely agree with you. But for the rest, orthopedics, for example, and so on, the engineers will be basically carrying out the gesture. They will not be making the decision, the rheumatologist will. But this is what I'm trying to say, because the implementation of this decision will be for them. So from the point of view of the finances, well, it's basically the efficiency and the relevance of the acts has to be taken into account. Yes, indeed, I understand, and this is probably the third point that we should tackle here that has been already mentioned before. These are the algorithmic processes and the AI that is more and more intervening in the surgery, the robotics, but also the medical responsibility. Because you know that there was this article in the Public Health about L4001 that was saying that the patient first and foremost must be informed. And I have seen that some people more and more start saying, I am using the robot, and the conceptors of all of these products must also know how this product works, meaning that you must be an engineer, meaning that Mr. X, who created this product, has to explain to you how it works so that to be able to work with this robot. And finally, and this was the problem that we mentioned this morning, is that the patient has to accept in theory that the data of the intervention that we have just done will be used to put into this software, because this is part of the continuity of the process and also the increase of the algorithmic data and the improvement of the algorithms. So we need this data, and the patient has to accept it in theory. So, well, the responsibility, just to come back to it and to finish on it, we haven't had any lawsuits yet in terms of in civil court or in criminal court about the robots, but it's written in the European Act that we have to be vigilant here, and we need to have a responsible practitioner, a responsible doctor. So I don't know who is this doctor, but this doctor will be basically liable in terms of all the technology that is being used here. So this is the problem, because it's not very clear for me, at least. Well, I'm not a specialist of law, but we will be able to know who from the biological operator and from the digital machine will be liable, because this can be just one of them, or just either of them, or both of them, or it can very well be a shared responsibility. It's a little bit like in a plane. And just to finish on this, it is very clear that, for example, a surgeon can also feel bad during the operation, feel sick during the operation, and so on, which is why some people are having two surgeons at the same time. But we can also imagine the cyber attack of the robot that is in surgery right now. So this is also a big topic because we have been talking about the radiotherapy. And just imagine that you have the software with all this data, with this precise data and so on, and then there is the cyber attack that is happening right at this moment, and you are burnt just because the program of this cyber robot has been changed. So this is it. Thank you very much. It was a pleasure for me to talk to you.